So next, we're going to have Dr. Jonathan Calkwood, and Dr. Calkwood is going to be speaking about visual issues with multiple sclerosis. I want to read to you a little bit about him. Dr. Calkwood is a neurologist and neuro-ophthalmologist specializing in multiple sclerosis. In 2006, Dr. Calkwood joined Randall T. Shapiro at the Shapiro Center for Multiple Sclerosis in Minneapolis, Minnesota. He became the medical and executive director at the Shapiro Center in 2008. He currently serves as the medical director of the Center for Neurological Visual Disorders, Vision Disorders, and the Neuro Visual Diagnostics Laboratory at the Minneapolis Clinic of Neurology. These people always want to trip me up in their long words, all right? But Dr. Calkwood is actively involved in clinical research as a principal investigator in multiple sclerosis, clinical trials, and has published research on multiple sclerosis and neuro-ophthalmology. Let's welcome Dr. Calkwood.
Thank you, Stuart. Thank you. Great introduction. You did very well with the not tripping up.
Thank you.
Well, great. So I'm happy to be able to talk to all of you about vision disorders and MS, a subject I'm passionate about. And understanding that, too, we need to keep a little levity. Dr. Shapiro was famous at a time when perhaps we didn't have effective treatments for MS, or sometimes no treatments for MS when he first started treating patients. And he would often tell his patients, well, we can laugh or we can cry, so let's choose to laugh. So yeah, it takes a minute, right? So some of you may remember probably 5-6 years ago, there were a couple of these actually weren't my pilots on the flight down here, but 5-6 years ago there was a flight, it was a Northwest Airlines flight, in fact, where 2 pilots overflew the Minneapolis airport all the way into Wisconsin. Apparently they were busy. They said they were busy on their laptops in the cockpit and just didn't notice. So I suspect it might be these guys. I don't know. But anyway, so, but on a more serious but also somewhat humorous note, we talk about brain function and we talk about seeing. And I think many people feel that vision, that we see things with our eyes. In fact, that's not the case at all. Our eyes simply collect the data that then our brains process. Now here's a humorous cartoon that attempts to show the differences between men and women. I'm hoping I'm not going to get hashtagged for this, but essentially, yes, we do have different perspectives as well, but it's our brain and the interpretation of the visual information that our eyes collect that is really how we see, really what vision is, and then the processing of that vision. Of course, the brain is integrally involved in processing that visual information that you collect. And the optic nerve actually is an extension of the brain into the eye. So the optic nerve extends from the brain into the eye, and even the layers of the retina, as I'll show you on some slides later, the layers of the retina have different functions, and many of those layers of the retina are nervous tissue. The nerves in your eye are part of your brain. It is a projection of the central nervous system, and it's one of the few places we can directly measure the impact of MS on the brain. And I'll show you some data and some information later about that. So, in general, what is multiple sclerosis? So I think there's a lot of confusion about this, but it's clear, I think, that MS is an autoimmune disease, or at least the immune system is integrally involved in the production of the damage and the injury that occurs. So the immune system is clearly involved. Immune cells that don't belong there invade the brain, the spinal cord, and in fact, immune cells kind of set up shop in the brain, and they may sit there and just continually pick away at the brain. Generally, the brain does not have immune system activity unless there's a reason, like an infection. When there's an autoimmune disease, like multiple sclerosis, the immune cells, for reasons we don't understand fully, are called into the brain where they cause damage and scars, also known as sclerosis, and that can occur in many different locations. The brain is certainly involved. The optic nerve and the spinal cord is primarily considered the central nervous system. I think I would leave this one to Dr. Hunter to explain. We were discussing this, and he, this isn't supposed to be on the humor slide, but there actually are some similarities. You could perhaps think of acne or MS as acne of the brain. There certainly are some similarities, but in general, I guess one difference is nobody can see your lesions and plaques like they can see your acne. And steroids, by the way, anyone who's ever been treated with steroids, and even if you don't have acne, you will get it if you have steroids. So almost any symptom, neurological symptom of MS, including some vague symptoms like fatigue, which is really hard to nail down. It can be a muscular fatigue. It can be an overwhelming lassitude where you just don't have any energy to do anything, even though you may not feel weak or may be able to do something. You just don't have the energy or even the desire to do it. So principally, the connections within the brain are damaged, and the interconnected areas of the brain become damaged. And that becomes very, very important, both in the visual system and in terms of how the brain functions and the issues, symptoms, and problems that people with MS develop. I'm going to go over a little bit of the anatomy, so when we get to some of the more technical data I'm going to show you and imaging of the back of the eye and nerves in the eye, we can have the same kind of terminology here. So in the panel on the right, you see a schematic where the optic nerve is in the background, and there's a slice through the optic nerve just to give you to see essentially where that is. On the diagram of the cut eyeball, you see the optic nerve in the back. Two important structures that are really important to MS is the optic nerve and the macula. And it turns out that there are nerve fibers in the back of the eye that emanate from that optic nerve and spread out in a very predictable pattern. Here's a diagram of these retinal nerve fibers where the circle in the center of the crosshairs is the macula, and then the larger circle is the placeholder of your optic nerve. There are no nerve fibers on the optic nerve itself. The fibers and the pattern you see coming out of that central disc are the individual nerve fibers. Now these nerve fibers are coming from all over the retina. The cell body of the nerve sits in the retina, and then the axon of the nerve, the wire if you will, then continues on through the retina into the optic nerve, and then the optic nerve carries that information off to the brain, where where your brain, as we said before, you see with your brain through visual processing. So one thing I would like to point out to you is there's a bundle of fibers that you can see directly between the two small circles. It makes a little sort of loop, and you see all the other fibers looping around it. That is called the papillomacular bundle. For reasons that aren't entirely clear, multiple sclerosis preferentially damages this layer of nerve cells in your eye. We can use that both for diagnostic purposes to help diagnose someone with MS, and as I'll show you some further data, we can use visual measures, including the thickness of that nerve fiber layer, to determine even perhaps how well your MS treatment may be working for you. So, so keep this in mind as we go through. Now, if we take a little closer look here, and now this is centered, the red box is showing you this section of the slice essentially through the back of the eye. And the image you see below, the colored image there, is actually a image from something called optical coherence tomography. Optical coherence tomography, we'll just call it OCT from now on. So OCT is able to measure in great detail these various layers of your retina. If you see on the black and white diagram on the right, it shows you what these layers are, and the initials refer to different layers of the retina. The very top of the diagram is a layer on the black and white diagram on the right shows some small nerve cell bodies, and then these nerve cell bodies are then contributing their axon to that layer that sits on the inside of the eye. Now, in the colored diagram below here, what we see is the gray, as opposed to the colored area, is actually the back of the eye, and the gray is inside of the eye. So it's a little perplexing. However, the nerve fiber layer sits on top of the retina. Well, if you have nerves on top of the retina, how does the light penetrate through the retina to get all the way to the photoreceptors that you see at the very bottom of the diagram. Those large cells, photoreceptors, are actually the cells that receive light information and are really the first step in some of the processing. Now, all of these layers of nerve cells in your retina are interconnected. There are other nerves interconnecting between different layers, but primarily we'll focus on two issues. The nerve cell bodies that exist in the macula are very important, and I'll show you some data on this shortly. And then the retinal nerve fiber layer, which is that very top striated layer you see on that diagram. So the question I asked related to how are you able to see if there are nerves on top of your retina? Well, it turns out that those nerves are not myelinated. Nerve cells are completely clear and the light passes through them. The nerve cells don't begin to myelinate until they form the optic nerve. So myelination or demyelination, such as optic neuritis, doesn't occur actually in the retina. Demyelination can occur in the optic nerve and, of course, elsewhere in the brain. In general, I think if you have MS, we have to distinguish visual issues due to MS and visual issues for other reasons. And I commonly have to remind myself and remind others that people, other physicians, I think that people with MS are just people. They get the same diseases and the same things that normal people get. And sometimes we doctors kind of have our blinders on and we start thinking that everything that happens to you is related to your multiple sclerosis. And that may not be true. So it's important in general to have good, regular eye health. So good vision health means regular eye examinations. Those eye exams are screening for things like glaucoma, for cataracts. Dry eye and cataracts are very common in people with MS. Dry eye can occur because of some of the drugs that we use to treat, such as bladder symptoms occur, bladder medications commonly worsen or cause dry eye. We also see cataracts more commonly in MS. And this is in part due to, well, people with MS are just people, right? You get cataracts, but when we use steroids, steroids are a very useful and important treatment when we're treating a relapse, but they do have consequences, and one of those consequences is accelerating the development of cataracts. So in patients who have been treated with steroids repeatedly, they are much more likely to get cataracts, and there are certain types of cataracts that are much more common if you've been treated with steroids. So if you have MS, it's even more important that you get your eye examinations done on a very regular basis, typically every 2 years for a young person for refractive glasses checks. There is also screening for other issues such as ocular melanoma. In addition to the glaucoma we mentioned. MS-related issues, we can see ocular misalignments that can produce degrees of double vision. We can see painful eye conditions. We can see disorders of tracking, disorders of what we call saccades, or making a rapid volitional eye movement from one target to another, for instance. And then in addition to the various issues that occur in the optic nerve itself. And then there are some visual symptoms that result that are very, very nebulous sometimes, like contrast sensitivity problems, and I'll endeavor to explain that here in a minute. So here's an example of some MRIs, and we see, of course, on these MRI images that while there are lesions apparent in the brain and the brain tissue, these scars in these locations don't really impact people's vision directly, although they might impact the visual processing. When you undercut these visual interconnections that the brain uses to process, it can slow down processing. Just as we see in the cognitive dysfunction that occurs in persons with MS, we can see an issue with visual processing that parallels cognitive dysfunction, or sometimes is separate and distinct from it. So while these may not directly cause vision problems, they can indirectly. And of course, lesions in the brainstem can impact the ability to control eye movements. can cause nystagmus, ocular misalignments, double vision, and various other issues. So here's another image of a slice through the brain. Now this is a coronal image sliced in this plane. So you see in the lower portion, the center portion, 2 round circles, and inside of that circle is should be a little dot, at least on the right side of this image, which is actually this individual's left optic nerve is bright. The dot in the center, you see a bright dot in the center, and that is optic nerve enhancement. This is an indication of acute optic neuritis. There's inflammation in that optic nerve, which is why the dye that's injected into the vein then leaks into the optic nerve when we do the MRI. And you need to do the MRI by appropriate techniques that are designed to enhance the ability to detect this subtle, what can be sometimes very subtle inflammation. So it's important then that to image the visual system, but imaging the visual system isn't terribly sensitive with MRI scan. There are other ways to do this. There's at the arrow you can then see the contrast enhancement, and again the optic nerve on the opposite side is not enhancing. Here's an example of a lesion in the brain stem. Lesions in the brain stem can impact ocular motility, smooth pursuit, tracking, nystagmus, stability of gaze, stability of vision. So that would be an example of a MS lesion that could directly impact visual function. So as an example, if you have these 2 examples using essentially electricity to light the light bulb, and what is the pathway? As I alluded to before, these lesions disrupt the interconnections in the brain, and they can interfere with processing, and primarily this shows up with speed of processing. So in this schematic on the left you see a few lesions, but the pathway is pretty much unscathed, goes all the way through, so the electricity gets through to light up the light bulb. The image on the right, however, where you see something that looks more like Swiss cheese, where there's been a lot of disruption to these fiber tracts in the brain. And then you see this kind of circuitous workaround, and then the bulb gets lit, but it's kind of dim. So that, I think, is a good analogy to think of in terms of what happens over time as you accumulate more and more lesions, and whether it's visual processing, whether it's cognitive processing, whether it's some other neurological function, cognitive or spinal cord mobility, sensory, bladder issues. The same principle applies throughout the central nervous system. These lesions again disrupt, and then they produce symptoms. So if you have damage in your optic nerve, this is an attempt to say on the top schematic, is that the new Corvette? Maybe I need to get my eyes checked, but I saw a picture of that one recently, and they look very nice. But the red color here is what you want to look at. So on the left side, we have a very saturated image. The red is very bright and intense, and as the patient looks through their left eye, that's the image they see. It's clear and crisp, and when you look, and then the patient looks through the optic neuritis eye, through the right eye, and you see essentially that it's not quite as clear, although you see pretty well, but the color is washed out and dim. So very important. Now this could be acute optic neuritis, when the vision is maximally impacted, and optic neuritis evolves kind of slowly over a few days to a few weeks, and then you get this recovery. So over time, this person's visual dysfunction may in fact recover, but the 2 most common residual visual problems that somebody has after they've had essentially complete recovery from their optic neuritis is color desaturation, so reds and greens especially aren't quite as bright, and an issue called contrast. I will show you something in a minute to try to give you a sense of what contrast vision problems can appear like, but in day-to-day life, essentially contrast problems show up when there is flat or gray lighting conditions. I live in Minnesota, and in fact it's snowing there now, and our first snow of the year in October. And when you are in the snow, and skiers of course can relate to this, these subtle contours are really difficult when the light is flat. So a skier may use tinted glasses or tinted lenses to improve their contrast, and in fact you can do that for MS as well. And I'll show you again a few examples of some contrast impairment. The panel below shows double vision, or attempts to show double vision. Now there's one very, very important thing to understand. If you ever have double vision, regardless of the cause, double vision is a very common symptom. So if you don't have MS and you have double vision, don't necessarily run out and think that you have MS. But there's a few observations you need to make. It's very, very important to understand when you have double vision. Your doctor needs to understand and if you make a few careful observations, it will help your doctor understand what's going on. So if you ever develop double vision, the most important thing to understand is that neurological double vision, the types of double vision we'd see from MS, occur when your eyes don't line up. When one eye is looking over here and another eye is looking over there, they see two different images and your brain doesn't know what to do with that. So if you have neurological double vision and one eye's looking here and one eye's looking there, if you close one eye, double vision goes away. Close the other eye, double vision goes away. If you have double vision just in one eye, in other words, if you close one eye and you still see double, and then you close the other and the double goes away, the problem's just in one eye. And that is not MS related. So your doctor can definitely benefit from that observation, especially if the double vision isn't present when you go in to see your physician. So when you go see your doctor, you may get something called a refraction. This is a way to check to make sure that it's not something simple like you just need glasses. And as you see the image on the right, the phoropter is the tool that measures, and I'm sure many of you could repeat verbatim, which is better, 1 or 2. 1 or 2. You've probably heard this quite a bit if you've gone to the eye doctor, and that is a very, very old tool, and we're still using it. There are electronic versions of autorefractors, but that's still probably the most widespread tool in use in the eye doctor's office. Astigmatism is another thing that can be corrected with glasses and is not due to MS. It's easy to determine if you have astigmatism simply by the phoropter and what we call refraction you've seen previously on the previous slide. But blurred vision can be interpreted as double vision, and you actually can have blurred vision in both eyes that looks like double vision, so that when you cover one eye, the double vision doesn't go away, but it gets a lot better. Then you cover the other eye, the double vision doesn't go away, but with the two eyes working together, the double vision is worse, meaning that you have double vision in both eyes. So that's possible. Still, that can be easily determined. Now, what about the optic neuritis? So this is another example of optic neuritis. The arrows point at some contrast enhancement. I mentioned the vision declines over several days and will begin to recover within a couple of weeks. If we do nothing about it, initial events of optic neuritis generally recover pretty well, at least in most people. Sometimes there's a prolonged recovery, or we may have profound vision loss from the first event, or bilateral vision loss, which might indicate actually another demyelinating disease. By 3 months, the majority of people have recovered their vision to 20/40 or better. Unfortunately, about a third of people will have double vision recur in the unaffected eye within approximately a 10-year period. And if you've had optic neuritis, there is greater than a 90% lifetime risk that you're going to develop multiple sclerosis. Optic neuritis by itself, if you have MS, may not be a bad prognostic sign. It is a sensory event, and especially if you have good recovery. Again, I mentioned this already, that a very severe optic neuritis or bilateral could mean a different disease. And in most cases, even though your vision may recover, there may be permanent irreversible vision loss that occurs in terms of the nerve cell loss, even though your vision may seem pretty good, or you may read 20/20 on the eye doctor's chart. So here's an example of a normal appearing optic nerve, and this would be a swollen optic nerve. 1/3 of the time in people who come in with optic neuritis, and I have to say actually these issues are reversed there. 1/3 of the time patients will have a swollen optic nerve that the eye doctor can see. 2/3 of the time, in fact, the optic neuritis is not visual to the eye doctor. After optic nerve damage, we can see paleness develop in the optic nerve, where we see at the arrow there's a waxy yellow color that is developed. And that's an indication, even if your vision has recovered completely to quote unquote normal, that's an indication that permanent vision loss occurs. The typical event of optic neuritis kills, on average, 20% of the nerve cells in the optic nerve. Obviously, if you've had repeated attacks of optic neuritis, 20%, 20%, 20% can really add up to really some profound vision loss. Here's one of the ways we can measure the impact of optic neuritis, and it's called a visual evoked potential test. This schematic shows shifting the checkerboard is a pattern that will then shift back and forth, and then the patient views this shifting checkerboard images. There are little electrodes placed on the scalp, and those electrodes record the electrical activity, and from that electrical activity we can determine if there is slowing in conduction of the optic nerve, which is the hallmark of optic neuritis. So here's an example. Hope none of you get seizures or migraines, because that little diagram in the corner is can be a little irritating after a while. The top pattern shows a visual evoked potential, and look at the and the squiggly lines there. If you can look at that without the shifting checkerboard there. There's a difference between the normal and the abnormal in that peak that points down. And that is typically that delay in conduction is what that is showing. We have and so latency is what we call that. We have a newer, more specific and much more sensitive test called a multifocal VEP, and that's that shifting pattern that you see. And I'm now going to move the slide because that was getting to me a little bit. Now, this is a study done quite a while back that attempted the colored circles on the bottom. Now, each of these MRI panels are separate patients. The colored panels on the bottom are their optical coherence tomography measurements. So the measurement of the densities of the nerve cells in the back of their eyes. The MRI images are images of brain atrophy, and as you can see, the black fluid-filled spaces in the center of those images in each of those three patients increase, showing each of those patients having more and more atrophy. The numbers along the bottom are the actual measurements of the thickness of the brain cell density in the back of the eye from OCT. And so we've known that OCT correlates with brain atrophy. And in fact, I use OCT in my clinical practice to identify someone when they're losing nerve cells faster than aging. I can often detect that on an OCT before we can see it on an MRI. Early warning is always good. This is one of the things I do with most of my patients. Now, here's another tool that we use regularly called contrast sensitivity. At the top panel on the right, this is a little different type of eye chart than what you might see at your eye doctor. This is called a Sloan low contrast acuity chart. And essentially, the black letters on the white background would be equivalent to the visual assessments that you do when you go to your eye doctor. However, that's not what most people with MS have problems with. It is this chart on the bottom where persons with MS follow, whether they've had optic neuritis or not. Many people with MS have damage in their optic nerve, and their contrast sensitivity is impaired. So if you have MS and you've never had optic neuritis, but your vision doesn't seem quite right, especially if it's flat lighting conditions, gray overcast days, might be something going on in your optic nerves. Again, lots of other reasons for that could be present, such as dry eye, cataracts, things that we've talked about before. So this is not only a research tool, but this is something that could be used by neurologists in their office to monitor patients with MS for change over time that might be very important. This just gives a general sense of the relative sensitivity. It's much more sensitive than ultrasound, and our most sensitive diagnostic scanning technique, confocal microscopy, is more sensitive than OCT, but OCT is very, very sensitive. We can measure down to microns of thickness in the back of the eye. Here's what a typical OCT printout might look like, and you can see the colored images in the squares on the top, and you can see differences. The dark circles in the center on the top panels are optic nerve, and the red colors coming out of that show the density of the nerve fiber layer, and you can see in the panels, right eye compared to left eye, OS being the left, OD being the right. and typically in the world of ophthalmology, everything's backwards, right? We say the right eye, we always present on the opposite side. So in this case, we see there's thinning of the nerve layer in the optic nerve in the patient's left eye on this image. And then the image on the bottom is imaging of the macula, what I mentioned before, those nerve cells and the ganglion cells, the nerve cell bodies that exist in the macula. And you can see a difference in the density, again, between the right and the left eye in these maps below. This is something called perimetry or visual fields. You may have had one of these done in the office, and you can see in your ophthalmologist office is something that we monitor with our patients in the neurovisual diagnostic lab. And we can see these differences. So this would be an example of serial changes over time in somebody with MS, where they are gradually losing nerve cells. Perhaps the panel on the right could show the sudden change over time could show an optic neuritis. Typically, this is what we do to measure the impact of the damage. Now, many people with optic neuritis will recover their visual field loss. And again, the typical, most common things that are left over, even if people recover completely to normal, is subtle contrast sensitivity and maybe color vision problems. So vision's represented differently in the back of the eye, and like everything else with our bodies, everything on the left winds up on the right side of our brain, everything on the right winds up on the left side of our brain. This panel on the lower left shows us just how that vision is divided and those pathways split at what's called the optic chiasm. The panel on the right attempts to show a pathway called the MLF. This pathway is a very slender pathway of nerves in the brainstem that keeps the eye movements yoked together. So horizontal control of eye movements. The thought originates here to look to the left in the right prefrontal cortex. And then the nerves go down to the brainstem, and we see this pathway of input that's blocked. The little X blocks the pathway of the MLF. Well, when those nerve fibers tell the brainstem to stimulate the eyes to look to the left, both eyes have to go at the same time exactly. The yoking of those eye movements occur through that pathway called the MLF, and that pathway is commonly damaged in people with MS. This will cause a problem, as you see in the cartoon, where one eye goes this way and the other eye doesn't. In fact, sometimes you will even see something where there's some coarse beats of nystagmus when the patient attempts to look to one side or the other. If a young person develops an intranuclear ophthalmoplegia, it is almost always MS. Older people may be prone to develop vascular disease, so strokes and various vascular issues can occur in people who are older. So, but this is something that's very, very common in MS and should increase the concern for MS if someone's diagnosed with an intranuclear ophthalmoplegia is what it's called. There are other issues that can occur as well. Nystagmus is kind of hard to describe. I can wave my arms around and do a few things like that, but you're better with videos, so there's some links to some videos of various ocular issues. And nystagmus, of course, is difficult to treat. Nystagmus generally in MS occurs because of damage in the brainstem or cerebellum. It can be very localizing. Nystagmus can be horizontal, it can be vertical, it can be rotary, it can even be different in the two eyes. In MS, because the damage in the brainstem is really diffuse, we can see all sorts of ocular motility issues develop, including different patterns of nystagmus that sometimes don't really follow the rules. They don't stick to certain types. You can have rotary and jerk nystagmus, vertical or horizontal, in the same patient at the same time. So, NMO. This is a condition that is not MS but looks very much like MS, and we in fact used to lump it into as a type of MS that we called Devick's disease. So now we call it neuromyelitis optica because we've identified it as different immunologically. There are antibodies that are elaborated. It is very rare compared to MS. The aquaporin 4 antibody can be tested in the blood, but it's not always positive in people who do have NMO. Optic neuritis is often the presenting feature of NMO, and if you've just had optic neuritis, it may look pretty much like MS. However, it tends to be much more severe with incomplete recovery, and often it will present with bilateral loss of vision at the same time. So bilateral optic neuritis, or optic neuritis that attacks the optic chiasm, is much more likely to be a neuromyelitis optica. Transverse myelitis is damage in the spinal cord. This disease causes large segment damage or long segment damage lesions in the spinal cord and can lead to paralysis, and again, the recovery is often incomplete. Interestingly, this condition can also lead to intractable nausea and vomiting. Brain lesions may not look like MS exactly, but they can be close enough to be confused for multiple sclerosis. I'm going to show you some data quickly because we mentioned contrast sensitivity. Here's a treatment trial from a study on natalizumab or Tysabri. And in these two studies, we see the two lines basically showing that the patients who were not treated versus the patients who were treated, in terms of the dotted line were the patients who were treated. And over time, the patients who were treated with natalizumab had less vision loss. We see a similar from a research study on alemtuzumab, where we actually saw improvements in contrast sensitivity over the course of treatment that were quite prolonged over time. We've also seen studies that have shown improvement. This was a natalizumab study that actually showed improvement in the visual evoked potential of the shifting checkerboards that I showed you previously. We mentioned cataracts, already talked about this as far as the impact of corticosteroids and the need for you to get regular eye examinations. There might be some things that we can do in terms of sending you to a low vision clinic if you have a lot of damage in your optic nerve. You see in the middle some tinted glasses, yellow tinted glasses can improve that contrast vision loss. They're not just for skiers, and in fact, I ask my patients to keep a pair of these in their car in case they ever need them. Just a few vision tips as far as things that we might do. Separate glasses often may be helpful. Tints and various other things can help improve that as well. And I will leave you to read those on your own. And I now will yield to Dr. Cantor.
Thank you.
Thank you very much.